introduce our speaker today. We have one of our speakers who is Dr. Nkechi Obianozie. I'm trying to remember how to pronounce it the Igbo way. So that we do not murder your name. Dr. Nkechi is a consultant in internal medicine, neurology in the University of Abuja Teaching Hospital. So I'm sure some of you on this call will know who Dr. Nkechi is. She has over 20 years work experience as a doctor, and she has also worked within the public hospital and within the NGO space. So she has experience on both the coin. She's also, she teaches as well, and she's a mentor. So who else but her to teach healthcare workers how to teach their patients self-management skills? She's a member of the Movement for the Society Africa Education Sector. She is also an active member of the European Stroke Organization, World Stroke Organization, Nigerian Society of Neurological Sciences, American Academy of Neurology, amongst others. She's part of the cardiovascular research training setting organized recently in Abuja. So those joining from Abuja, I'm sure you've encountered Dr. Obianozie at one point or the other. She's passionate about stroke prevention through education and has published work in journals on cerebrovascular disorders like stroke, and she has also carried out research in other neurological fields like headaches and movement disorders. She's currently researching migraine phenotypes and is an international collaboration sponsored by International Headache Society. So she's eager to share information on stroke prevention, especially hypertension control. That's why she's here. She also remains committed and passionate about the work that she's doing, especially when it comes to even teaching and passing knowledge. So please give a thumbs up in the chat or on your profile for Dr. Nkechi Obianozie. I can clap because everyone can hear me clap. So the rest of us, can we give a thumbs up in the chat for our speaker today? Okay, can we go to the next slide? So we would also have Dr. Aima Uwagboy speak to us just immediately after Dr. Obianozie. Dr. Aima is a clinical advisor here, and she is an associate fellow NPNCN. She has obtained her degree from the University of Port Harcourt and is an associate fellow of the National Postgraduate Medical College of Nigeria, Obstetrics and Gynecology. She has also worked at the Morehouse School of Medicine and the Women's Healthcare Center in Georgia. An International Disease Federation certified professional, and she has facilitated trainings on multiple areas when it comes to chronic disease management, diabetes, and the management of diabetes in pregnancy. She's passionate about disseminating information on maternal health, self-care, and it motivates her to write abstracts, to write work that have been accepted in scientific conferences. She has the desire to continue to push for timely and effective healthcare delivery for women and children. She has a strong interest when it comes to the subject matter that we're discussing, and we'll hear from her very quickly immediately after Dr. Obianozie. So please, thumbs up again for Dr. Aima Uwagboy in the chat, and we will very quickly hand over to Dr. Nkechi Obianozie, who will be taking the first part of the presentation. Over to you, Doctor.
Good afternoon, everybody. Thank you for that nice introduction. So I'm going to be going through teaching hypertension self-management to our patients. And next slide, please. I'm Dr. Nkechi Obianozie, and I work in the University of Abuja Teaching Hospital. So to start with, I think we all are aware of the fact that hypertension is the leading modifiable risk factor for stroke, and other cerebrovascular diseases. And this was highlighted in the Interstroke study and the Siren study. And the Interstroke study, which was a multi-center study around the world in 32 countries. And it actually showed in the first graph here that hypertension was the leading modifiable risk factor for stroke. And that in general, in the Siren study, which was a study more local to us, where you had participants from Nigeria and Ghana, and they were able to look at 3,000 cases and controls. And again, they found that hypertension was the leading risk factor for stroke, a modifiable risk factor. But what I wanted you to also bear in mind is the fact that for us that are Black people in sub-Saharan Africa, hypertension becomes even more important because you can see how far high up that bar chart is for hypertension. So always, hypertension is one of the top things on our minds when we're talking about risks for cerebrovascular diseases like stroke, like acute coronary syndromes, and for premature mortality, end-stage renal disease, in general, as we said, also all-case mortality, as well as blindness. So the JNC8 keeps the levels that for which we should use to define hypertension a little bit, not as stringent as the American College of Cardiology. So they use 140/90 as their baseline, while the JNC and the American College of Cardiology wants us to use 130/80 as a cutoff mark for hypertension. But we all know that perhaps this may also be related to so many things, including access to care and the fact that you would have to offer people treatments at lower levels. But according to a paper by Odili et al., we found that we actually have a prevalence of hypertension about 38.1% on an average in Nigeria. And this is similar within the sub-Saharan Africa region. And you have these ranging all the way from 20% in the North Central, where I live, and highest values in the Southeast, where up to half of the population is actually hypertensive. Next slide, please. So what is self-management in terms of hypertension? So WHO actually describes it as a capacity of an individual to manage their own health condition, with or without the support of the provider. So the provider can be part of it, or he may not be, but ideally, of course, we would all prefer for the provider to be part of it. So it's the ability of an individual to manage whatever health condition they have. And the methods include things like education for patients, self-monitoring of clinical data and behavior, including diet, exercise, and other factors, as well as titration of medical management. So in certain disease conditions, it's actually also able to teach the patient how to modify their medications by themselves without actually seeing the provider. As well as included in self-management by WHO is also the support you give your patient for medication adherence. Next slide. Next slide, please. So what is the role of the cell for patient in terms of according to WHO? So this is just explaining that at the level of the individual, it includes interventions to promote awareness about self-care. It also includes other things like interventions to allow for autonomy, for them to be able to take charge and be confident about their own health and how to manage it. And also, it also includes other things like health information seeking. So they should be able to acquire health education and to be able to have that education to be able to make informed choices about their healthcare. It also includes social and community support. It also includes personalized or personal health tracking, so they can have their own data records. Either it's a simple exercise book or whatever it is, the device that they actually use to check their blood pressure, for instance, can also be a health tracking device for those which store that information. Self-diagnosis of health conditions, self-management of your health. So all these are components that were described by WHO as part. In terms of the next slide, please. Can I have the next slide, please? So what about the health worker's role? So what is our role as a health worker for us to be able to help our patients be able to, to be part of the self-management of whatever health condition they have? So WHO describes it as under these subheadings. So one of the examples is for us to provide information according to protocols. So according to like science-based evidence on self-care interventions, we should also be able to demonstrate and provide instructions for correct use of teaching patients self-management of hypertension. We should be able to demonstrate and provide instructions for our patients on how to use their home blood pressure machine properly, how to keep records properly, and the information that you would require to be able to make decisions to further help them in their self-management. It also includes other things like peer communication, referrals, and then other parts of the health team, laboratory and diagnostic data management for self-care interventions. Next slide, please. So now, what do we mean by hypertension self-management? So it's actually a management strategy in which for blood pressure control, and it includes medication adherence, self-blood pressure monitoring, and lifestyle modifications that will involve diet as well as exercise. So it's not just medication adherence and self, it's also the lifestyle that they will need to modify. Also, it's coaching them through that as well. So it's a management strategy that involves all these prongs to bring together a proper strategy to help this patient. So as part of this strategy, it's also taught that patients should measure their own blood pressure in non-clinical settings. And there have been many studies to support the fact that this has been found to be superior to traditional office-based hypertension management. So what does that mean? They've done studies in which they said, okay, go home and have this machine, check your blood pressure. And they actually found that in such patients that there was actually a better outcome in terms of blood pressure control when they were able to monitor themselves in a setting that was not a clinical setting. Next slide, please. So home blood pressure measurements actually result in more frequent blood pressure measurements, as some of us can attest to, and it helps one to be able to better assess the degree of your patient's blood pressure control. So when we're talking about risk factors for cerebrovascular diseases, one of the things, apart from blood pressure being at target, which is like 140/90 for most conditions, certain conditions less than 130/80, and in some cases even more stringent. You also have to realize the fact that there's also the chance of blood pressure variability. That also has something to do with cerebrovascular disease and mortality. So your patient knows she's coming to clinic today, which is what we see sometimes in the hospital. And for the 2 days or 3 days before she comes to clinic, she's taking her medications regularly. And by the time you see her blood pressure, you're like, oh, you're wonderful, 120/80. And that's the only snapshot you have of this patient's whole clinical history for the last 3 months. Quite unlike a patient who has been monitoring their blood pressure at home. And then you ask them, can I look at your records? Can I look at your little notebook or your app where you put your, and then you begin to see that, oh, there were these days when you're getting 115/90. And she says, oh, I traveled to the village, or I went for my brother's wedding, I left my medication at home. There's an excuse here and there. And so then you're able to now identify the fact that there have been days when the blood pressure has not been what you are seeing today at the clinic. So that's what they've found, that home blood pressure measurements result in more frequent blood pressure measurements, and it helps you to assess the degree of your patient's hypertension. And then when you now combine this hypertension self-management with team care, in which your BP data from home monitoring is now communicated to a healthcare provider, you have even better outcomes in terms of blood pressure control. Next slide, please. So this is part of what we have to explain to our patients, that with increasing blood pressures, you have increasing risk of cerebrovascular disease. On the left is a chart that shows the risks that rise, the way the risk rises with the higher blood pressures for coronary artery disease. We mean like myocardial infarctions, heart attacks. And then we also have for stroke mortality on the right. And we can see that from blood pressures ranging, so the safest blood pressure from all these studies is about 115/75. And as then you get higher and higher in terms of blood pressure, you're having more and more of a risk of what? Mortality. So you can see from 120, the risk of what? Coronary artery disease, and then stroke mortality. And the same also goes for other things like chronic kidney disease and other risks, peripheral artery disease, etc. Next slide, please. So this is why we need to explain to our patients, and we need for them to understand the fact that hypertension is better managed than you having to deal with the end products of stroke or heart disease. And so when they begin to understand the risks that are involved, they are also more prone to be able to be adherent to their medication. So patients need to understand that they need to sustain the use of their blood pressure medications. So a lot of times what we see in the clinic is people come and say, doctor, I came and then they said I was hypertensive, they put me on medications, but after like 1 or 2 months, I checked the blood pressure and the blood pressure had come down. You were like, okay, but were you not taking your medication? They were like, yes, I was taking my medicine. I thought that the blood pressure was now normal and I decided to stop my medication. But they need to understand that their blood pressure was low because they were taking the medication. So the blood pressure medicine was actually doing what it ought to do. And sometimes you may think this is something that they already know, but don't take it for granted. Many of our stroke patients actually had this kind of story. My blood pressure now came down. And when it came down, I now stopped the medications, but I did not continue to check my blood pressure. Another thing we tend to hear is, doctor, I went to my pastor and I went for a prayer service and my pastor said I've been healed. So I threw away all my medications. And as one of my mentors, Dr. Oji, always says that every miracle has to kind of like be confirmed. And so when you have to now educate the patient and tell them, well, if you believe that this miracle has happened, then we need scientific proof. That means that you have to check your blood pressure consistently and show us that it has been low without medication for us to be convinced of your miraculous miraculous recovery. Then we have to devise as providers ways to encourage our patients to be adherent. And in that sense, I always want to encourage our providers, whether it's the nurses, your health worker, whoever is in contact with these patients, please always remember to ask for the blood pressure monitor notebook or for the app where they save the data and actually look at it and comment. This really helps with adherence. Because when they see that you are, you're interested in what the records they've been keeping, they tend to be also, oh, I took my medication in the morning, I checked my blood pressure. They tend to be more motivated to do it. So what do we now tell them? So for the younger people, I tend to realize they are more internet savvy. I always tell them, go online, download an app, use the mDoc app, because the mDoc also has one, the Complete Health. You could also, any other app that you feel comfortable with using, use alarms on your phone to help you to as reminders. And then of course, the traditional methods like pill counting can also be an option. And then some people like the old fashioned, keeping a small notebook and a pen, and then just writing the dates and the blood pressure. So usually we encourage them to check their blood pressure 2 or 3 times in a week, sometimes in the morning, sometimes in the evening. And then we also explain to them that blood pressure tends to be variable during the day. So these are things that you have to keep explaining to the patient as well. Next slide, please. So we're also supposed to kind of work our patient through the lifestyle modifications. So self-management of hypertension also involves lifestyle modifications. And the lifestyle interventions include the use of in general, what is recommended by the JNC8 and the other hypertension work groups are the dietary approach to stop hypertension, the DASH eating plan, as well as weight loss, then a reduced sodium diet, so less than 2.4 grams per day, so less than a teaspoon, and at least 30 minutes of aerobic activity most days of the week. So your patient may ask, what do you mean by most days of the week? We usually interpret that to be 5 days, about 5 days of 30 minutes of exercise. Some books will say you can also make it 1 hour of every 3 times a week of moderate aerobic activity. So in addition to delaying the development of hypertension and improve the blood pressure, and then lowering the effects of existing medication and decreasing cardiovascular risk, alcohol on its own should also be limited to 2 drinks daily in men and 1 drink daily in women. And in fact, the newer studies are actually showing that that, to be honest, no amount of alcohol is really safe. So it used to be thought of as that J-shaped curve between cerebrovascular disease risk and ischemic stroke, for instance, and hypertension and alcohol. But actually, it has been found that even small amounts of alcohol increase the risk, and that was in the journal, the JAMA journal in 2022. But in general, it's said that 2 drinks daily in a man is safe, and about 1 drink daily in women is what we call safe. But then what is 1 drink? You need to be able to explain that to the patient. So 1 drink is actually 12 ounces of beer. So it depends on the percentage of alcohol within the alcoholic beverage. It's 5 ounces of wine, because wine usually has about 20% alcohol, or just 1.5 ounces of 80 proof liquor. So if your patient is somebody that drinks vodka, or sometimes those, they have, some of our patients drink these sachets, hard liquor that they drink, they sell them in the small shops. So you have to explain to them that that's just about 1 drink. So they are only allowed to have about 1 of that in a day. That's what's considered generally safe. And then quitting smoking also, because it's been found that it also reduces cardiovascular risk. Next slide, please. So we're supposed to encourage our patients to stop smoking, and the strategies that we should use are actually strategies that should be scientifically based. So these involve things that have been proven to work. It's not easy to change behavior, as many of us can attest to. And it includes things like counseling. Counseling, for those of us that in our centers where we have clinical psychologists, you could refer them to the clinical psychologist. You could also refer them for behavioral therapy. But I've found also that for those of us working more at the community level, that sometimes we have semi-trained counselors in terms of our priests, our traditional, like the head of the groups. Some of them are, well, not really that they are trained, but they have a way of being able to reach out and be able to convince people to make changes in their behavior that will affect their health. So if you don't have a clinical psychologist, you don't have anybody formal, you could still use informal methods to help your patient to stop smoking. There are also certain medications that can be used, and these include nicotine-containing products like nicotine patches. There's also the chewing gum that they can use. Some of these are available in our environment, but they are a little bit pricey, as well as nasal sprays. Then, as again I mentioned, you also have to keep educating the patient on the risks of alcohol and the effect of alcohol in terms of cardiovascular health. So I just mentioned again that the recent article in JAMA 2022 actually found that even small amounts of alcohol may be increase the risk of cardiovascular diseases. Next slide, please. Next slide, please. So, as we're explaining to them again, sometimes we need to use practical things to show the patient what a drink serving means. So usually we'll tell them, okay, this is a glass, or this is a glass of beer that's actually 1 serving. So usually I think that most standard bottles of beer would be about what we're seeing here. And so that's about 425 mils, just about that. And then, of course, some of the stronger spirits, as I mentioned, just about 30 mils of that. And so that's just like 6 teaspoons is actually 1 drink. And then for wine, about 100 mils. So that's, you can just imagine about half a glass of a standard wine glass. So these are things that we need to kind of explain to them, that this is what is actually said that is relatively safe in terms of the risk when associated with hypertension and other risks for cerebrovascular diseases. Next slide, please. So the next component of self-management would include self-blood pressure monitoring. So self-monitoring of blood pressure is the regular measurement of blood pressure by the patient outside the clinical setting, either at home or elsewhere. And I like to sometimes use this allusion to the fact that some of us that work in the poorer communities understand the fact that sometimes your patient may not be able to afford to buy their home blood pressure machine. So I want to reemphasize that this definition says that it's measuring the blood pressure outside the clinic setting. So it must not necessarily be at home. It could be in the community center. It could be in the church. It could be in a chemist near their house, or any center that is not like a formal clinic setting. And it could also involve the fact that maybe you go to your neighbor's house, they have their blood pressure machine, and asking them, oh, please come, let me use, Mama Adora, you have a machine. Let me come and check my blood pressure tomorrow because I want to take my records down. So it must not be in their own home, and they must not have their own machine. So it's once they measure their blood pressure outside the clinic setting. And so it requires the use of a home blood pressure measurement device by the patient to measure blood pressure at different points in time. So usually we recommend that some of the measurements should be in the morning, some should be in the evening, and so that we can have an idea of what their blood pressures are like during the day. Next slide, please. So what are the instructions we need to, because we need to explain to them how to take their blood pressure properly. And so this is a schematic kind of explaining the whole process. So the patient should actually sit calmly, and they should be with their feet on the floor for about 5 minutes or more. They should not be talking. They shouldn't have consumed any caffeinated beverage, including Pepsi, Coke, Lipton tea, coffee, any of this. And they shouldn't have exercised or had any food at least 30 minutes before doing this. And after that, they should take 2 readings, 1 minute apart, and they should take the readings in the morning before their medications, and actually also in the evening before dinner. They should record their results. Usually we like a small notebook or an app or whatever they need. And then we should also make sure that the cuff size and that the calibration of the machine is correct. Because if you're using a blood pressure cuff size that is too small, you're going to be having abnormally high readings. If you're using one that's too big, you're going to be having abnormally low readings. So you must ensure that the cuff size is appropriate. We also have this problem of sometimes with these digital monitors that sometimes the measurements do not match what we get in the hospital. And so we tell them, bring it to the hospital, we'll check and we'll use it together. Sometimes it's just a problem with the batteries. Sometimes some of the pharmacy reps tell us that they need to be calibrated from time to time. So they need to we also need to be aware of this to be sure that the recordings that they're getting are accurate. So the tips that I have are ask the patient, as I said, to bring the monitor to the center for calibration so that we can check that it's commensurate with what we are getting in the clinic. And then we should check that the batteries are working and check that the cuff size is appropriate for our patient's size. Next slide, please. So the steps are the patient should prepare themselves. That means the 30 minutes before, no eating, no drinking as we measure. They should position themselves sitting on a chair with their table up, and then they should then measure with the home blood pressure machine. Next slide, please. So these are the ways we can teach. Then we can also use this mnemonic, the 5 R's. I liked it because it's easy. They should rest for at least 5 minutes. The other slide said 30 minutes. Usually they're different. It varies between what you see in different guidelines. But in general, they should rest for between 5 minutes to half an hour before. They should refrain from taking from talking while they're taking their blood pressure, and they should not have any constrictive clothing around their upper arms while they're checking their blood pressure. And they should make sure that their arm is supported on the surface with the cuff at the heart level. So they should remember that the cuff and the machine should be at the level of their heart, right? Like this young lady sitting down. And then their feet should be flat on the floor, because if they cross their legs, of course, you're going to have higher recordings than you would have wanted. So, and then you should take 2 blood pressure readings about 1 minute apart. And then you should also tell them what their goal blood pressure should be. Ideally, for most people, less than 130/80. Next slide, please. So this is another schematic just explaining the same thing and showing the fact that, re-emphasizing the fact that the blood pressure machine should be at the level of their heart, and that they should sit comfortably on a chair with their feet flat on the floor. Next slide, please. So what is the correct cuff size? So the guidelines show that the cuff width should be about 20% more than the upper arm diameter. So the cuff width should be quite, should cover at least, the way I'll put it, about, the whole mid part of their arm, and that it should go around 40% of the circumference and 2/3 of the arm length. So if you measure the circumference of their arm, it should be 40% or more of the width of the circumference of their arm. Next slide, please. So what about lifestyle modifications? So we need to be able to explain to our patient the need to have this science-based data that shows that a low sodium diet, high potassium diet, which includes things like green leafy vegetables, citrus fruits, etc., a diet rich in fruits and vegetables, and minimally containing processed foods, trans fats. So the way I used to explain it sometimes to the patients would be to tell them things like, you see all those things that children eat, all those biscuits and cookies and meat pies and all that, those are all no-nos for you. Try and eat natural, the way our parents used to eat in the old days. So going back to our old ways of eating, processed foods should be eliminated as much as possible. And then food also low in trans fats. And what is actually recommended is the dietary approach to stop hypertension. And that's next slide will detail more about that. Next slide, please. So it just says that the diet should have more fruits and vegetables, and that we should cut back on food that has a lot of saturated fat, cholesterol, and trans fats. So when the patients will often ask you, okay, doctor, which of the oils would you recommend? Of course, the olive oil is a good way to go. Olive oil is not affordable for a lot of our patients. So we tend to ask them, all the vegetable oils are usually low in cholesterol, but not all vegetable oils are low in saturated fat. So I tend to say, okay, those peanut oils, so the peanut oil is also safe, low in cholesterol, canola oil, soya oil, they all tend to be low in what? Cholesterol. Now, palm oil, you say, oh, but it's a vegetable oil, but it's high in what? Saturated fat. So even though it's low in cholesterol, then we now have that problem of our saturated fats. Please, next slide, please. Okay, can we go back? I think we're done with that. Okay, no, can we go back 1 slide, please? Okay, 1 slide more, please. Okay. So we're back. Are we going backwards? Sorry. Could we go backwards to this last slide I used, the one on the saturated fats? Yes, I just wanted to mention that the modification of the DASH diet, which included the DASH sodium, is just a modification where they implied the fact that limiting sodium to less than 1,500 milligrams daily is actually recommended. So some books will tell you 2,300 milligrams, that's about 1 teaspoon. But they find that even when you reduce it even further, it's even better for blood pressure control. And I remember that from a lot of the interactions that we have in our hospital, they keep saying that Black people tend to be very sodium sensitive. So sometimes just by this simple modification of reducing sodium, you're able to see significant changes in blood pressure measurements. So we also advise them, of course, to limit the sodium, to limit their sugary drinks. And then, as we said, red meats. Next slide, please. So this is a schematic explaining again the DASH diet. So the DASH diet, when you break it down, is actually saying that daily you should have about 7 to 8 daily servings of grains, and then 4 to 5 daily servings of vegetables, 4 to 5 of fruit, then 2 to 3 of low fat or fat-free dairy products. And then you should just have 2 or less daily servings of meat or fish. Now, what do you mean by a serving? Because your patient is going to be asking you, can you explain this to me? And a serving is actually a very small portion of food. So it's 1 cup of vegetables that are uncooked, or half a cup of those same vegetables that are cooked. So that means that if you're having vegetables and you say, oh, I'm watching my weight, I'm following the DASH diet, and then you have like a big bowl of pineapple, 1 whole pineapple that you sliced, that certainly maybe is like 20 servings of fruits. So that's your serving size for fruits for 4 days that you've consumed at a sitting. So they're actually saying that you should have about 4 to 5 daily servings of fruits. What is 1 fruit serving? 1 medium apple or a small banana, not the very big bananas that you see sometimes. 1 cup of canned fruit that has no added sugar, right? And then you now see also that even the amounts of meat, which is like your fish, 2 or less daily servings. And then 1 serving of chicken is just 80 grams. And while a serving of fish is about 100 grams, which is just a very small or moderate size piece of fish. So you can imagine that these portions are actually quite small. And that's being able to interpret this also for your patients so they understand what you mean. Just 1 slice of bread is a serving, okay? So next slide, please. So this is a schematic also explaining what we said. So sometimes for some of us that we have patients both with hypertension or diabetes or trying to lose weight, sometimes we just use a general thing and tell them, okay, if your plate is a round plate, we divide it in half. Half of it should be your vegetables. We give you an example like okra soup or vegetable soup. So one of those vegetable-based soups. And then out of the other half, you divide it into 2. 1/4 of it should be a small portion of chicken or fish, and then the other portion should be your gari or your rice. Then you get about maybe 3 servings or 2 servings of the grains, and then you get about another 3 servings of vegetables in that kind of portion control. So that's the kind of like things you need to interpret for your patients. Next slide, please. So for people with hypertension, regular physical activity can bring the blood pressure down to safer levels, and it has been proven. And although the gains may be modest, there are also other gains in terms of not just reducing blood pressure. Hypertension, exercise has been proven to improve endothelial dysfunction. So the very core of what is going wrong in terms of what puts you at risk of cerebrovascular disease, it tends to tackle it at that level, not just only in blood pressure gains. Then what are the examples of aerobic exercises you can ask your patients to do? It include things like walking to work, or when they're coming to work, to stop at the junction before their office, if they normally take a cab or the bus, and then walking to work. And so you're sure they're getting maybe 20, 30 minutes of brisk walking early in the morning. It also includes jogging, cycling, swimming, or dancing. So these are all aerobic forms of exercise. Then your patient now asks you, oh, but doctor, I prefer to do like weights. Is that the same thing? So you can explain to them that, well, yes, resistance training also has modest benefits. So it has modest benefits. So the benefits are there, but not as much as it is for aerobic exercises. So in general, most of our patients, I just said, walk more, try and buy something like, put an app on your phone or on your watch, and something that can help you be accountable and ensure you get about 6,000 steps, which is what is about the minimum. It takes you about 30 minutes. If you're walking very, very briskly, it can take up to an hour to get about that 6,000 steps in a day. And then another possibility also is high intensity interval training. For those who do go to the gym, they may use shorter periods to do high intensity bursts where they really sprint for a short time and then they rest, sprint. So they can get the same effects with that as well. Next slide, please. So these are some of the exercises you can recommend, even skipping, then taking the stairs at work for those who live in buildings who are very high. That could also be a form of their aerobic exercise every day. Dancing, things that they like to do. They can just put on a disc, turn on YouTube, put on a playlist that they enjoy, and just dance for 30 minutes. So it doesn't always have to be in a gym or something formal for it to now make it beneficial to them. Next slide, please. So these are just some of the simple strategies that I mentioned already, and trying to explain to them that they could also, things to motivate them, find a friend to work with, find an accountability partner, use an app on your phone, find a watch that has a pedometer, or download one and put it on your digital device. You can actually use a step counter for those who have one available. Next slide, please. So these are like analysis that showed that blood pressure reductions with aerobic exercises. So you're expecting maybe about 7 for systolic, and you're expecting about 5 for diastolic blood pressure drops, right? So it's not like you're expecting these, but this can mean a difference between somebody going on an additional medication or somebody reducing the cardiovascular risk by a significant amount. Remember, we said that increasing level, the higher, the more the chances of a stroke or a heart attack, etc. And for resistance training, as I said, the benefit is there, but perhaps not as much. You can lead to lowering of the blood pressure on an average about 4 millimeters of mercury for systolic, and the same thing for the diastolic, about 3.6 for diastolic blood pressure. So you see, not as robust as for aerobic exercises, but still present. Next slide, please. So what are the other lifestyle interventions? You know, there's all these, I mean, we're all going through a lot of stress now because of the situation we're facing in various communities with cash traps, etc. So we also have to teach our patients how to manage. There will always be stress. How to manage these stresses that are invariably part of life, so that it does not affect their blood pressure and their risk for all these strokes and other and heart attacks, etc. So stress management, however, if they like to go out to meet friends, to have some social events, we should encourage them. They should also, if they are under a lot of stress, they may actually need some counseling to help them to manage their stress better, which, as I said, can involve your spiritual director. It can involve a good trusted friend. It can involve more formal people like your clinical psychologists and your psychiatrists. Yoga is also a good way of reducing stress, meditation, and other means that you can be creative in advising your patient, depending on your locality and what you find. I find like some of my patients, they're active in their church groups. And I said, okay, but does that make you happy? They say, yes, when I go there, I forget all, I feel so. I said, okay, do more of that. Do more of what relaxes you and makes you happy. So a lot of that is context driven. I know some of us may not have access to yoga, etc. Next slide, please. So adherence is part of, and follow-up is part of self-regulation. It involves attendance at follow-up clinics. So if you know that nobody is going to look at your values, you find you're less motivated to do it. So it's part of self-regulation, involves the patient following up and coming for follow-up visits. And the appointments may be virtual. For now, we have access to internet-based telehealth, etc. Even mDoc has similar things. Or it can actually be in person, where they actually come in to see their health provider, their nurse, their health worker, and they discuss the values that they've seen. And home blood pressure measurements are usually reviewed, and then we adjust your medications. We ask, how are you doing with your lifestyle modifications? Sometimes we're so pushed for time that what I try to do is I try to pick one aspect of lifestyle to discuss per patient, per visit. It's not always possible to go through everything and say, okay, but how are you doing with your diet? Are you reducing the salt? Are you finding it more palatable? because you know salt is kind of a taste that you acquire. I said, now that you've reduced the salt, so sometimes just encouraging them, you get used to it, hanging there, just maybe 30 seconds, 1 minute, 2 minutes, talking about their about the advice you want to what you want to give to them, and then adjusting their medications based on the values that you've seen as well. And then we must keep educating them on the need for them to keep checking up and to keep coming in for follow-up, and then identify possible needs and then be able to address them in a timely manner. So what is it that you think you need to be able to go through with this lifestyle measure better? Do you think if you had an accountability partner, you or a friend that you talk to go with you for your walk, would you be better at going for your daily walks? You know, try just, you know, normal things that you out of your, you know, being a bit creative can think up to help your patient meet the needs for them to be able to go through with their lifestyle interventions. Next slide, please. So we educate them on their blood pressure targets as well. So as I said, blood pressure targets vary depending on the patient's comorbidities and depending on the patient's age, their tolerability. Some people have a lot of autonomic dysfunction from diabetes or from other conditions like Parkinson's disease. So you have to know what your patient's blood pressure targets. But in general, 140/90 is what people advise for. Some of us use more strict targets of 130/80 for our stroke patients. And then, so we advise our patients on that. We advise them on how to monitor their blood pressure, recording. We keep educating them on the lifestyle modifications, the importance of it. And then we identify the barriers and obstacles to their self-management. As I said, I'm trying to be creative and work around them to help them and help them to overcome these barriers. Next slide, please. So from the clinic, these are things I have just picked up from managing patients. As I keep mentioning, always ask to see the recordings. So please ask, it helps patients stay motivated. Always check that the machine is calibrated properly and that they are using the proper size cuff. And always encourage and motivate, be positive. Those are always very helpful. Next slide, please. So in conclusion, self-management of hypertension has been scientifically proven to have benefits for hypertension control. And in general, care providers, we are all critical in adapting strategies to help patients adhere to these medications, their medications, and the lifestyle changes that are necessary for us to be able to implement this management strategy. And I keep using this word adapting, because many of us that are working in low-income areas, sometimes you can't really tell people about a DASH diet or something like, but when I go to my private practice and I see the more well-to-do ones, I can tell them, let's read more, let's see a dietitian. But for those that are on the whole, that are the majority of who we see and cannot afford a dietitian, changing it into practical things that they understand. Okay, you cannot afford to buy kale, or you cannot afford to buy those vegetables that are in that beautiful dash diagram, but you can afford greens from the Malam on your way home. 100 naira greens, you buy it. You can afford okra, you can afford water leaf, you can afford a wedu. So you have to kind of try and make this practical for your patients, right? And so that's what I talk about, adapting management strategies to our own local needs and being creative, because this is what is needed in our low-income settings. Thank you very much for listening.
Thank you so much, Dr. Obianozie. Thank you. That was really detailed. Thank you for sharing from your wealth of wisdom. We have a few questions, but I think we'll take the questions at the end. We see some thumbs up in the chat. Thank you so much. So we'll jump very quickly into the second presentation. This is just going to walk us through how this self-management skills can be taught. Okay, what are some of the principles that are leveraged, using some examples that already exist within the mDoc space as well. So we will be letting Dr. Aima take over. Please feel free to keep sending your messages in the chat. We will take your questions in the chat. We will take them immediately after Dr. Aima, and then we'll go to the case presentation. So over to you. Can you hear us, Dr. Aima?
Yes, I can. Thank you,
Okay,
Adora,
great.
and good evening, everyone. Okay.
So you have
All right,
about
good
10
evening.
minutes, and I will prompt you so that we can make sure that we get everything correctly. Go on, please.
Perfect. Thank you. Good evening, everyone. So today I'm going to be talking about how we actually go about supporting our members at mDoc Healthcare who are living with hypertension. So a lot of what Dr. Obianozie has kindly done has laid the background, what I'm about to discuss, because she has about the guidelines and how we should manage or support these patients. So they are your patients and they are our members at mDoc Healthcare. They are not our patients, because at mDoc Healthcare, we do not prescribe medication, but we have medications that our members need in order to live healthier and happier lives. Thank you. Next slide, please. Forgive me, I think bandwidth is a bit low, so I may have to, yeah, it's really low. Okay, so our approach at mDoc Healthcare involves, onboarding. I'll be talking a bit more about what that involves, creating bespoke action plans, motivational interviewing, building digital literacy amongst our members, and then building self-efficacy as well. Next slide, please. So how do we go about onboarding? Next slide, please. Onboarding just means where we meet our patients. At mDoc, we like to say that we meet our patients where they are. So onboarding could be in the field. Onboarding could be a member in their home who wants to log on to Complete Health and has been shared a link by which they can join mDoc. So Complete Health is our digital health social platform where we support our members living with hypertension and other chronic disease conditions as well, and our members who just want to stay healthy and well. And so the member has signed on to Complete Health. And so we ensure that we do take their baseline investigation. So this is just similar to what we need to do in the clinic. So we need to go through the detail of getting their biodata, their health, previous medical history, who is hypertensive in the family, so that you know how to holistically support this member and this your patient. So this is what we do at mDoc Healthcare. Next slide, please. And so after the member has been onboarded, the member has joined on to mDoc Healthcare, and then we go about to ensure that we get the information from the member. So the way we go about this at mDoc Healthcare is by motivational interview. This just means that we ensure that the means by which we get the information and the counseling that is done with the member enhances the member's desire to make a change in their behavioral patterns or habits. Remember, I said that key to us at mDoc Healthcare is lifestyle modifications, ensuring that the member changes the way, the thinking, and then the thought process and how they actually go about, ensuring that their blood pressure, in this case, becomes better. And so it involves, next slide, please. It involves pulling the member and carrying the member along in the whole process. So that means that we need to not just, so next slide, please. So it's not just, immediately correcting the member, you shouldn't do this or you shouldn't do that. It involves, calming down, listening to what the member has to say. Because we've noticed that when you do this, you actually, get that intrinsic motivation for change from the member. So we should ensure that we do this with our patients as well. We resist the reflex to, correct the patient immediately, which is the writing reflex, or the member immediately, and then we try to understand what the member's motivations are. So why is it that you're eating a whole plate load of fufu every day and you're living with hypertension? What is the challenge? Member may have some problems at home that makes him to do that financially and does not know, to Dr. Obianozie's point, that you can get this cheaper vegetable available just beside you that can substitute for, what you're trying to eat to fill yourself up. And so we understand the intrinsic motivations of these members. We listen with empathy to them so that we can help solve their challenges or their problems. And then before we go about empowering them with the information that they need. That is the RULE acronym. So let's remember as healthcare workers to follow the RULE acronym with our patients. Next slide, please. Okay. And so the coaches, like I said, would have listened to the member. They would have listened to all about what the member has to do. And then they go ahead to give the lifestyle modifications, and 99% of the time, the member is not at the healthcare facility. Next slide, please. So you can see on this particular slide, I don't know if it's a delay on my end, but the particular slide that is up is just the mDoc health coach doing her thing in our in-person Nudge Hub. And so that's just similar to what would happen between you and your patients in the clinic. And then we go ahead to listen out. Now, remember, we have listened holistically on all the problems the patient is having or the member is having. And then we now go ahead to say, okay, what is it you want to achieve by coming towards us? This is what your blood pressure is at the moment. Where do you think you should be at in 2 months, 3 months, knowing fully well and having been educated on what, this elevated blood pressure could mean to your health? And so can we work together to create SMART goals? This is the action plan. It has to be SMART goals. So we ensure that whatever we and the member are deciding on this co-creation plan is specific, it's measurable, it's achievable, it's realistic, and it's timely. Yes, what you may want to achieve in the next 2 months may not be similar to what you want to achieve in 4 months' time. So we take it bit by bit and we walk the member through this to ensure that they achieve this goal that they seek to. So they would agree on a target for example, like you can see an action plan there telling the member on the DASH diet and how they should take their fruits and vegetables 50-25, 25% in respect of the vegetables, in respect to the lean protein, and in respect to the grains that they should have in their meals. So they are working together, the two of them. So is it their weight? What weight do you want to achieve in the next few months? How do you think that we can get there? Okay, so let's set a target for that. What is your exercise like at the moment? And what do you think you can work towards achieving with respect to the guidelines that have been given for exercise of 150 to 300 minutes a week? And so the member and the coach worked together on this, and then guiding them also, nudging them on adherence to their medications and what they need to do to adhere, right? And then sometimes we even encourage them to Dr. Obianozie's point of stepping, and your coach reaching out to you to say, this is the time for your medication for a member who, for instance, is having challenges adhering to their medications, and then reminding them to rest and sleep as well. Next slide, please. So like I said, we ensure that we develop an action plan, and then we also ensure that we build, it's key to us at mDoc Healthcare that our members have digital literacy. Most of our work, or a lot of our work, is virtual, but while we've also gone ahead to focus that or to observe that they do need that in-person touch for some members here and there. So we then go ahead to teach them and train them when they do come on to our Nudge Hubs, which is, just in-person care places where they come in and they learn how to, check for their blood pressure, their weight circumference. So you have a lot of elderly people wanting to actually do that. So mama wants to check how to actually check this waist circumference that she needs to log on, or check her blood pressure, or check her weight. And then we teach them how to do this, and then also teach them how to walk through complete health. I'm aware of my time, Dora. So next slide, please. Yes. So that is for building literacy for us at mDoc Healthcare, and then building self-efficacy, like I said, is key. So if the member does not know how to check her weight, if the member does not know how to check his or her blood pressure, they are less likely to do so, and they're less likely to achieve the health outcomes that they so desire. And so we ensure that, we teach them how to do this, as much as we can. We try to even share videos for those that are, virtual videos where they can learn how to do this by themselves. So a video showing you how to, check your blood pressure, check your weight as well. We also ensure that we do that at mDoc Healthcare. Next slide, please. And so BP monitoring, blood pressure monitoring is key for those living with hypertension. You can see a graph there showing a diligent member who, when the blood pressure was very high, was checking very frequently. And then you can see that the member rested a bit when, the blood pressure had come a bit under control. So you see that as soon as you log on this blood pressure, this weight, this whatever that metric is on complete health, it shows in a graph-like form, which you can just go and show to your healthcare provider, your doctor, at a glance. So it's good for, how we doctors can do. Okay, write it in a book. When you check your blood pressure, write it at the time you checked it, right? So the member doesn't really have to go through that, but here she can just log it on to complete health and then come and show it to the healthcare provider in the clinic. And for those who do not have access to do that, it's also key just like Dr. Obianozie has said, that they monitor their blood pressure so that they can know whether they are going towards their goal or going further from it. So that is very key to us at mDoc Healthcare. All right, just like we can see on the graph here from the member. Next slide, please. And so ensuring, weight monitoring as well. We can see somebody, so as soon as you enter on your weight, your BMI, your weight and your height, your BMI is automatically calculated, which is your body metabolic index that tells you whether you're overweight or not. And so not just your weight graph, you can see whether you are getting towards your goal of being normal weight or, whatever it is that you aim to achieve. And so we know that, according to AHA guidelines, when you lose 1 kilogram of your weight, your blood pressure drops by about 1 millimeter mercury. So it is key to us that our members with hypertension track their metrics effectively so that they can achieve, reduced blood and sustained controlled blood. Next slide, please. Next slide. Yes. And so how do we go about helping them with their meals? I think that, for healthcare providers, like to Dr. Obianozie's point of, with the busy clinic that you have in front of you, visuals are very effective. We believe in visuals. So we could find a way to, just like we have in our hypertensive clinics, have more of those up, of the DASH diet, so that at a glance, the member comes in, they can see what their dietary plate should look like, or at a glance, they can see what a portion of vegetable looks like. You say it, but if they see it visually, or rather if they have the visuals, it helps them to understand what exactly that portion is like. Because for we Nigerians, one of our challenges is, that food is interesting. So you want to finish it, you want to eat enough. So bring it down to the right level that you should, with the right amount and the kind of food is what we do. We go ahead to share nutritional meal cards, just like you can see that the member can take home or the member can have on the health platform to, adhere to. So not specified, this is what you should eat, bread and egg in the morning, yam and this in the afternoon, but rather, showing them a lot of healthy foods that they can combine together to achieve this DASH plate that we just spoke about. Next slide, please. So that is one of our ways that we build self-efficacy amongst our members. Another way is by adherence to medications. And so we do this by, like I said, healthy reminders and nudges for our members to do so that while we have not prescribed these medications for them, their doctors have prescribed the medications, we are supporting them to obey what their doctors have said so that they can live healthier and happier lives. Thank you. Next slide, please. And so on exercise, we can see the graph monitoring the member's exercise right there in, on the slide. This is a member who has entered on an exercise, and then at a glance, you can see if she's achieving 150 to 300 minutes of exercise a week, as recommended by the WHO, and which would help her in turn to control her hypertension. Next slide, please. All right, so this is just how to sign up to our complete health platform. And before Adora kicks me out, so I think that's our next slide. And we'll be happy to support you and to support your patients that you send across to us to obey you and to do the needful. Thank you for your time.